Welcome to the deep dive. Today we're tackling a really specialized area, pediatric maxillofacial pathology. It's about the unique conditions affecting children's faces and jaws.
Exactly.
Our goal here is to really unpack the key insights, understand what makes these conditions different in kids, and, how it all connects to their growth.
It's a fascinating field, honestly. The rapid changes in a child's facial structure, the developing teeth, it creates a, well, unique environment for these pathologies compared to adults.
Right.
And while a lot of these are rare, understanding them is just crucial for the right treatment and really for safeguarding the child's future development.
That makes sense. A different landscape entirely.
Yeah.
So we'll look at this through two main categories, right? The odontogenic ones
Originating from tooth tissues.
and the non-odontogenic coming from other cell types.
Precisely.
Okay, let's dive in.
Hmm.
And I want to start somewhere maybe a bit unexpected. We often think pathology means serious stuff, but what about things in newborns that are actually quite common and will often just go away?
That's a great place to start, yeah. It shows how resilient kids' bodies can be. We often see things called gingival cysts of the newborn or Epstein's pearls.
Okay.
They're just tiny, superficial cysts. The gingival cysts pop up on the gum ridges, sometimes called Bond's nodules. Epstein's pearls are similar, but right along the midline of the palate.
And they're developmental.
Purely developmental. The key thing is they usually just degenerate or rupture on their own, typically gone by 3 months.
So for parents seeing these, it's mostly about reassurance.
Exactly. No treatment needed, just knowing it's often a normal part of early development. A good reminder that sometimes the body just sorts itself out.
Okay, so from those very early self-resolving things, let's move forward a bit. As teeth develop, other issues can crop up. What about cysts linked to impacted teeth?
Yeah, a classic example is the dentigerous cyst. This one forms around the crown of a tooth that hasn't erupted properly.
Impacted tooth.
Right. It attaches right at the neck of the tooth, the cemento-amyl junction, and it actually comes from the cells that form enamel. In younger kids, you see it often with canines or second molars. Later, in teens, it's more common with wisdom teeth.
And treatment for that, is it complex?
Usually, it's pretty straightforward. We do what's called enucleation and curettage. Basically, we carefully shell out the entire cyst lining
Okay.
and then gently clean the bone cavity to make sure nothing's left behind.
But what about the tooth itself? Especially in a growing child. You want to save it if you can, right?
That's a really critical point, yes. If it's a canine or a second molar, the goal is often to save the tooth. If orthodontics can bring it into the right position, then moving the tooth effectively treats the cyst too without extraction. Recurrence is rare, but if left untreated for a long time, these cysts can cause bone expansion or damage nearby teeth.
Okay, that makes sense. Now, moving from those relatively common cysts to something rarer but more serious, the ameloblastoma. You mentioned it's a tumor, an epithelial one.
Yes, an epithelial odontogenic tumor. It's rare in children, but it's something clinicians have to keep in mind when they see certain radiolucent lesions in the jaw.
Radiolucent meaning it looks dark on an x-ray.
Exactly. It shows up as a dark area. It's usually in the posterior mandible in kids. What we sometimes see in adolescents is the unicystic variant.
Unicystic, like looks like a single cyst.
Precisely, and that's the tricky part. Clinically and on x-rays, it can look just like a simple dentigerous cyst, maybe some painless swelling, maybe teeth shifting.
So the diagnosis might be a surprise.
Often it is. It might only be diagnosed after what everyone thought was a simple cyst is removed and sent to pathology.
Wow. So it's kind of hiding in plain sight. How does that affect how you treat it?
Well, for that unicystic type in children, the initial treatment is usually that same enucleation and curettage, like a cyst. But, and this is important, depending on what the pathologist sees under the microscope, if the tumor is truly contained or if it's starting to invade the cyst wall, then long-term follow-up becomes absolutely vital. Because these can recur, especially if it's what we call a mural type, meaning it's growing into the wall. For those, or for the rare solid forms, you need a more definitive surgery, a resection with clear margins.
Got it. Okay, let's shift gears slightly to another odontogenic tumor, the adenomatoid odontogenic tumor, or AOT. I've heard this called the tumor of two-thirds. What's that about?
Ah, yes, the tumor of two-thirds. It's a really useful mnemonic, actually. It helps spot AOTs early.
How so?
Well, the pattern is 2/3 of cases are in females. 2/3 are associated with an impacted tooth, usually a canine. 2/3 occur in the anterior jaws, and 2/3 are in the maxilla, the upper jaw. You can see these even in kids as young as 5.
That's quite a distinct pattern. And biologically, what is it?
Biologically, it's generally considered a hamartoma. Think of it like a developmental hiccup, a benign malformation of tissue that just grows along with the child, rather than a true aggressive tumor.
So not like the ameloblastoma then.
Mm.
Less aggressive.
Much less aggressive. Its microscopic appearance is also quite unique, which helps confirm it. Because it's well contained and not truly neoplastic in the aggressive sense, simple enucleation and curettage works very well. Recurrence is basically unheard of.
Okay, that's good to know. Now here's one where the thinking has really evolved, right? The keratocystic odontogenic tumor, KCOT.
Oh,
Used to be something else.
that's right. It used to be known as the odontogenic keratocyst, or OKC, but the World Health Organization reclassified it a while back as a neoplasm, a tumor, and renamed it KCOT.
Why the change?
Because despite looking like a cyst, it behaves much more aggressively. It has an inherent growth potential and a really high recurrence rate if you don't treat it properly, sometimes over 50%.
Wow, that high.
Yes. And in kids, we often see them emerge in the teenage years. They have a strong preference for the posterior mandible, and they're actually more common in boys.
So definitely not just a simple fluid-filled sac. It's actively growing.
Exactly. And there's another critical link, especially for children. If a child presents with multiple KCOTs, it can be a sign of nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome.
The genetic syndrome.
Yes. It involves mutations in certain genes and can lead to these aggressive KCOTs, multiple skin cancers later in life, and other issues. So finding KCOTs in a child means you really need to consider screening for NBCCS.
That's a huge diagnostic flag then. How does this aggressive nature and the potential syndrome connection change the treatment approach for kids?
It makes things more complex. Enucleation and curettage are still done, but often we'll consider decompression first.
Decompression, what's that involve?
It means creating a small opening into the cyst, maybe placing a little tube or drain to relieve the internal pressure. This lets the cyst shrink over several months.
So it makes the final surgery easier.
Exactly. It can make the definitive removal less invasive and hopefully reduce that high recurrence risk. But the absolute cornerstone for KCOTs in kids is diligent, long-term follow-up. We're talking years, even a decade or more, because recurrences can happen very late. Compliance from the patient and parents is key.
Okay, so we've covered quite a few tooth-related issues. Let's broaden out now to the non-odontogenic side, things not directly from tooth tissues. And I think a really crucial area, especially for kids, is distinguishing between hemangiomas and vascular malformations. They can look similar, right?
They can, absolutely, but biologically they are worlds apart. And getting the diagnosis right is fundamental because the management is completely different.
Okay, so break it down for us. Hemangiomas first.
Hemangiomas are the most common tumors of infancy. Often not present right at birth, but appear in the first few weeks. Think of the classic strawberry mark. The key feature is their life cycle. They have a rapid proliferative phase. They grow quickly, usually for the first 4 or 8 months. Then they enter an involution phase, where they slowly shrink and fade over several years. Most are gone, or much smaller, by age 5 to 7.
So they grow fast, then they shrink. It's a temporary thing.
Often, yes. It's an overgrowth of endothelial cells, the cells lining blood vessels, but it's programmed to regress. Now compare that to vascular malformations, VMs.
Okay.
VMs are different. They are structural errors in vessel formation arteries, veins, capillaries, lymphatics that are present at birth, even if they are obvious initially. Crucially, they do not proliferate and involute. They grow proportionally with the child.
So they don't shrink on their own?
No. They persist throughout life.
Yeah.
And things like hormonal changes, puberty, for example, can sometimes make them grow faster or become more apparent.
That's a huge difference. One fades, one stays. How can you tell them apart just by looking? Or is there a test?
There's a simple clinical test called diascopy. You gently press a glass slide or even just your finger on the lesion. A vascular malformation, which is basically a collection of abnormal channels, will usually blanch turn pale as the blood is pushed out. A hemangioma, being a solid proliferation of cells, typically won't blanch much, if at all.
Okay. That makes sense. And the treatment reflects this difference.
Completely. For hemangiomas, often it's just observation, letting nature take its course. If it's interfering with function like vision or causing cosmetic issues, medications like beta blockers can be very effective. For VMs, treatment depends on the type. High-flow arterial ones might need embolization. Venous or lymphatic ones might get sclerotherapy injecting something to collapse the vessels. Capillary ones, like port wine stains, respond well to specific lasers. It's about managing a permanent structural issue.
That really highlights why understanding the biology is so vital. Okay, let's switch tracks again. You mentioned conditions that are literally diseases of bone. Can we talk about fibrous dysplasia?
Sure. Fibrous dysplasia is a condition where normal spongy bone, the medullary bone, gets replaced by abnormal fibrous tissue and immature bone. In the head and neck, it loves the maxilla, the upper jaw.
And what does it look like, say, on an X-ray?
Radiographically, it often has this diffuse, hazy appearance, sometimes described as ground glass or like an orange peel texture, peau d'orange. It can affect just one bone that's monostotic or multiple bones, polyostotic. There is also a rare syndromic form, McCune-Albright syndrome, linked with hormone issues and skin spots.
What's the main challenge managing this in a child who's still growing?
The timing of surgery is critical. Because the bone is actively changing, if you try to surgically recontour or reshape the affected bone too early, before growth slows down after puberty, there's a pretty high failure rate, around 25%. The lesion can just grow back, sometimes even more aggressively. So the standard approach is often to wait until skeletal maturity, managing symptoms in the meantime. For the more severe polyostotic forms, sometimes medications like bisphosphonates are used to help with bone pain or prevent fractures.
Waiting must be tough, but it makes sense if operating too early makes it worse. Now, sticking with bone, but maybe slightly different, what about cherubism? The name sounds quite evocative.
It does. Cherubism is a benign hereditary condition affecting the jaws. It typically shows up in young children, often before age 5. The classic look is painless, bilateral swelling of the posterior mandible, the back of the lower jaw.
Bilateral, so both sides.
Yes, usually symmetrical. Sometimes the maxilla is involved too. If it affects the orbital floor, it can push the eyes slightly upwards, causing the whites underneath to show more, giving that cherubic or angelic facial appearance, hence the name.
Yeah, and radiographically.
You see multiple, well-defined, bubbly-looking radiolucencies, often making the teeth look like they're floating within these areas.
Is it something that needs aggressive treatment?
Actually, no. The remarkable thing about cherubism is that it's usually self-limiting. It tends to stabilize around puberty and then gradually regresses as the child becomes an adult. By age 30, the bone often remodels back to a near-normal appearance. So treatment is rarely needed unless there are significant functional or cosmetic issues.
Fascinating. Okay, shifting from bone to soft tissue masses in the neck.
Yeah.
What are some common congenital cysts or masses you might see there?
Two really common ones in the neck are the thyroglossal duct cyst, or TDC, and branchial cleft cysts, BCCs.
Let's start with the TDC.
The TDC is the most common developmental cyst in the neck, usually right in the midline. It's a remnant from when the thyroid gland migrated down from the base of the tongue during development. It can show up anytime, often around age 5.
Is there a key sign?
Yes. The classic clinical finding is that the lump moves upwards when the child swallows and when they stick their tongue out. That's almost diagnostic.
That's a neat trick. And treatment.
Treatment is surgical removal using a specific procedure called the cyst trunk procedure, which removes the cyst and the tract leading up towards the tongue base. But critically, you first confirm the child has a normal functioning thyroid gland elsewhere.
Right, don't want to remove their only thyroid tissue.
Okay.
And the branchial cleft cysts.
BCCs are the most common congenital masses on the side of the neck, laterally. They come from remnants of the branchial arches, think embryonic gill structures. They usually appear as a smooth, painless lump just in front of the big neck muscle, the sternocleidomastoid.
And treatment for those.
Also, surgical excision. It's important to remove the entire cyst and any potential tract to prevent recurrence or infection.
Okay, now we know malignancies are less common in kids, thankfully, but they do happen. Could you touch on one or two that are particularly notable or aggressive in the pediatric maxillofacial area, just for awareness?
Absolutely. It's important to be aware. One is Langerhans cell histiocytosis, LCH. It's a complex neoplastic disorder. In the jaws, it can cause these destructive, punched-out looking lesions in the bone.
Punched out?
Yeah, like someone took a hole punch to the bone on the x-ray. And this destruction around the tooth roots can give that really characteristic appearance of teeth floating in empty space.
That's a very vivid description.
It is. Diagnosis needs a biopsy. Treatment and prognosis depend heavily on how widespread the disease is, whether it's just in bone or involves other organs. It might involve chemotherapy or local treatments.
Okay, another example.
Another highly aggressive one is Burkitt's lymphoma. It's a type of non-Hodgkin's lymphoma. The endemic form seen mainly in Africa, very commonly involves the jaws, especially the maxilla.
What does that look like?
It presents with really rapid facial swelling, pain, loosening of teeth, sometimes even premature tooth loss. Microscopically, it has a classic starry sky pattern. The good news is, despite being incredibly aggressive, it often responds very well to intensive chemotherapy, with high remission rates in children.
Good to know there are effective treatments, even for something so aggressive. Okay, last area to touch on the salivary glands. What are some common issues there, specific to kids?
Well, probably the most common things we see related to minor salivary glands are mucocilious.
Mucocilious.
Yeah. It's usually on the lower lip. It happens when there's trauma, like accidentally biting your lip. A small salivary gland duct gets damaged or blocked, and mucus spills out into the surrounding tissue, forming a little fluid-filled blister or bump. Feels kind of soft, maybe bluish.
And how did you treat that?
Treatment is surgically removing the mucocell and the little minor salivary glands that contributed to it. If you just drain it or don't get the glands, it's quite likely to come back.
Okay, what about something similar, but in the floor of the mouth?
That's called a ranula. It's basically a mucocell specifically arising from the sublingual gland under the tongue. It causes this swelling in the floor of the mouth that can look a bit like a frog's belly. That's where the name comes from. Rana means frog.
Frog's belly, okay. Can they cause problems?
Oral ranulas usually just cause swelling, but sometimes they can dissect down through the muscle in the floor of the mouth into the neck. That's called a plunging ranula, and that can potentially cause airway issues if it gets large enough.
So treatment for ranulas.
For simple oral ones, sometimes an initial step is marsupialization, basically opening it up to create a pouch that drains into the mouth. But for plunging ranulas, or ones that recur after marsupialization, the definitive treatment is usually removing the entire sublingual gland on that side.
And briefly, what about actual salivary gland tumors in children? Are they common?
Salivary gland tumors are much less common in kids than adults, but they do occur. The most common benign one is the pleomorphic adenoma, usually in the parotid gland. Treatment is similar to adults, typically surgical removal.
And malignant ones.
The most common malignant salivary tumor in children is mucoepidermoid carcinoma. This can occur in major glands, like the parotid, or in minor glands throughout the mouth. It can even occur inside the jawbone sometimes. Its behavior depends on its histologic grade, low, intermediate, or high. Thankfully, the lower grade tumors often seen in childhood tend to have a better prognosis.
Okay, wow. We've covered a huge amount of ground, from those tiny newborn cysts right through to complex tumors and malformations. So pulling it all together, what's the main theme here?
I think the main theme really is the unique biological context of a growing child. Everything behaves a bit differently. The tumor of 2/3 pattern for AOT, the self-limiting nature of cherubism, the floating teeth of LCH, that critical hemangioma versus vascular malformation distinction.
Right.
Each one needs an approach that considers the child's developmental stage. You can't just apply adult principles directly.
And the implications are massive, aren't they? We're talking about growth, appearance, basic functions like eating and speaking. So getting the diagnosis right and intervening appropriately and at the right time, it's just critical.
Absolutely
It
critical.
makes you think, doesn't it? When we look at these advancements in diagnosing and treating these pediatric conditions, it's not just about fixing a pathology. It's really about preserving a child's ability to develop normally, to smile, to interact, to just be a kid. It shapes their whole future. So maybe the thought to leave with is, what's our collective responsibility to ensure every child facing these challenges has access to the specialized care and the expert knowledge they need?